Hello, everyone. Thank you for joining the 2022 Quality and Cost Performance Categories webinar. During the webinar, CMS subject matter experts will provide information on participation basics for the quality and cost performance categories, reporting and scoring requirements, and resources and support. This presentation will be followed by a question and answer session where attendees will have an opportunity to ask questions via phone in the Q&A box. And CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now I'll turn it over to Lisa Marie Gomez from CMS to begin.
Thank you. Next slide, please. This is just a disclaimer slide noting that all the information in this slide, in the slide deck, is accurate, but we do encourage all participants to go to the sources and our other materials that we have posted to get further and elaborate information relative to the information in this presentation. Next slide, please. During today's webinar, we will provide a quality payment program overview. We will discuss the MIPS, the Merit-Based Incentive Payment System, also known as MIPS. We will also discuss the 2022 Quality Performance category, in which will include basics, the reporting and scoring. We'll also discuss the 2022 Cost Performance category, which will outline the basics, the measures, and scoring. We will also provide help and support information, and then we will have a Q&A session. Next slide, please. I just want to highlight the MIPS exceptions applications. There are 2 exception applications now available to clinicians for the 2022 performance year. The Extreme and Uncontrollable Circumstances exception application allows you to request reweighting for any or all performance categories if you encounter an extreme and uncontrollable circumstances or public health emergency, such as the COVID-19 public health pandemic. And again, this is as a result of something that is outside of your control. The application deadline for this particular application is December 31st, 2022, 8 p.m. Standard Time, Eastern Time. So again, we just want to highlight that if you are encountering an extreme and uncontrollable circumstance or public health emergency, this application is available to you. The other application, exception application, is the MIPS Promoting Interoperability Performance Category Hardship Exception application, which allows you to request reweighting specifically for the Promoting Interoperability Performance category, in which your performance category will be reweighted to 0% if you meet certain criteria. The application deadline for 2022 is December 31st, 2022. So again, the 2 deadlines for these exception applications are December 31st, 2022. Next slide, please. Now I'm going to discuss the quality payment program and provide an overview. Next slide, please. The quality payment program. So the Medicare Access and CHIP Reauthorization Act of 2025, which is also known as MACRA, ended the sustainable growth rate formula, which would have resulted in a significant cut to Medicare payment rates for clinicians. MACRA advances a forward-thinking, coordinated framework for clinicians to successfully participate in the quality payment program, which is composed of 2 tracks. The first track is MIPS, which is the Merit-Based Incentive Payment System. And if you're eligible to participate in MIPS, you are subject to a performance-based payment adjustment. And then the second track is the Advanced Alternative Payment Models. And if you participate in Advanced APM and achieve qualifying APM participant status, or QP status, you may be eligible for a 5% incentive payment, or you'll be excluded from MIPS. Next slide, please. So when we think about quality payment program, there is an eligibility. So to participate in the quality payment program, as you can see on this slide, so eligible clinicians is considered anyone who can participate in an advanced APM or an APM, or in the MIPS program. So when we think about MIPS eligible clinicians, it gets a little bit more narrow. So MIPS eligible clinician, it's specific for someone who is not participating in an advanced APM, but you could be participating in an advanced APM. And there are certain criteria if you are participating in advanced APM. So one is that you do not have QP or partial QP status. If you do have partial QP status, you have the option to participate in MIPS. And if you do participate in MIPS, then you would be eligible for a payment adjustment under MIPS. And if you have a QP status, you're not eligible to participate in MIPS. And for those who are not participating in an advanced APM, you're eligible and participating in MIPS. Next slide, please. Now I'm going to discuss more details relative to the merit-based incentive payment system, which is also known as MIPS. Next slide, please. So I'm going to describe the performance category weights and the various different performance categories under MIPS. So for 2022 traditional MIPS, the performance categories and weights are following. So the one performance category is quality, which is rated at 30%. Cost is the second performance category, which is rated at 30%. There's the improvement activities, which is weighted at 15%, and promoting interoperability, which is weighted at 25%. If you're participating in traditional MIPS, but you're an APM entity participating, your weight is different than participating just in traditional MIPS. So your weight would be 55% for quality. Cost is not weighted. Your improvement activities is weighted at 15%, and promoting interoperability is weighted at 30%. Next slide, please. Now I'm going to discuss certain terms and timelines that are applicable to MIPS. So when we refer to a TIN, it's a taxpayer identification number, which is used by the IRS to identify an entity such as a group medical practice that's subject to federal taxes. An NPI is a national provider identifier, and a TIN NPI identifies the individual clinician and the entity, group, or practice through which a clinician bills services to CMS. And in regard to timeline, so for the 2028 performance period, the corresponding payment year is 2020, and the payment adjustment is up to 5%. For 2019 performance period, the corresponding payment year is 2021, with the payment adjustment of up to 7%. The performance period 2020, the corresponding payment year is 2022, with the payment adjustment up to 9%. For 2021 and beyond performance periods, the corresponding payment year is 2023 and beyond, and the payment adjustment is up to 9%. Next slide, please. I'm going to go over some more timelines specific to MIPS. So when we think about the 2022 performance year, the performance year begins January 1st and ends December 31st of 2022. And clinicians care for their patients and record data during the entire calendar year. When we think about data submission for the 2022 performance year, data submission actually occurs in 2023. So data submission for 2022 performance period begins January of 2023 and it closes March 31st of 2023. And clinicians are encouraged to submit data early during that time frame. Also during 2023, CMS provides performance feedback after the data submission is closed, and clinicians will receive feedback before the start of the payment year. Now with regard to 2024 payment adjustment. The MIPS payment adjustments are applied on a claims-by-claims basis to cover professional services billed under the PFS and rendered between January 1st and December 31st of 2024. Next slide, please. Now I'm going to discuss the quality payment performance category and provide an overview. Next slide, please. So the quality performance category assesses the quality of care clinicians deliver as evidenced by their performance on quality measures. Quality measures measure healthcare processes, outcomes, and patient care experiences. and they link to outcomes that relate to one or more of the following quality goals: effective, safe, patient-centered, equitable, and timely. Next slide, please. For the 2022 performance year, the quality performance category, as noted previously, is worth 30% of your MIPS final score, and is 55% for MIPS eligible clinicians participating as an APM entity. And this performance category has a 12-month reporting period. So it's from January 1st of 2022 to December 31st of 2022. Next slide, please. So in terms of quality measures, clinicians have an option to choose from an inventory of 200 MIPS quality measures. And below on this slide is an overview of the 7 types of quality measures you may report for the quality performance category. So the different types of measures are process measures, outcome measures, intermediate outcome measures, patient-reported outcome measures, structure measures, patient engagement or experience measures, and efficiency measures. And on this slide, it defines each type of these measure types. Next slide, please. The quality measure inventory includes high priority measures, which aren't an additional measure type, but they fall within the following measure types. So again, high priority measures are outcome measures that include intermediate outcome and patient-reported outcome-based performance, appropriate use, patient engagement and experience, patient safety, care coordination, opiate-related, and efficiency measures. So these are the high priority measures for the quality payment, for the quality performance category. Next slide, please. As part of the Meaningful Measures initiative, we continue to incrementally remove process measures in order to move toward more meaningful and robust quality measures. Prior to removal, we consider the following criteria, but this criteria is not limited just to this criteria, but it's the things that we do consider when we are going to potentially remove a measure. So removal of a process measure impacts the number of measures available for a specific specialty. A measure addresses a priority area highlighted in the measure development plan. A measure promotes positive outcomes in patients, considerations and evaluation of the measure's performance data, and measure is designated as high priority or not. We may also remove measures with low reporting rates for 2 consecutive performance periods. Next slide, please. Now we're going to discuss what's new for the quality performance category for 2022. So the quality performance category weight has decreased from 40% to 30% for individual MIPS eligible clinicians, groups, and virtual groups participating in traditional MIPS. And as noted previously, it's 55% for MIPS eligible clinicians participating as an APM entity. Again, the inventory of measures is 200 MIPS quality measures, including 1 new administrative claims measures. There are 87 existing measures that have substantive changes for 2022, and 13 had been removed from the program. So from 2021 to 2022, we removed 13 measures. And I just want to highlight that the last year for the CMS web interface that will be available as a collection and submission type will be the 2022 performance period. So right now, this is the last performance period in which the CMS web interface will be available. And starting in 2023, that's when the web interface will no longer be available. And this is just for those who are reporting and participating in MIPS, specifically under traditional MIPS. For those who are participating as a shared savings program ACO, the deadline for the web interface in terms of its availability, that availability will be through the 2024 performance period. Next slide, please. I just want to highlight that for the 2022, there are no bonus points available for reporting additional outcome and high priority measures, so beyond the 1 required, or for measures that meet end-to-end electronic reporting. So essentially, there's no more bonus points now in 2022. We'll only calculate a group level quality score for Medicare Part B claims measures if a practice submits data for another performance category as a group, signaling their intent to participate as a group. And additionally, quality scoring flexibilities for measure specification and or coding changes that occurred during the performance period were added for the 2022 performance period. Next slide, please. Also new for 2022 are several quality measure scoring policies, which were finalized for 2022 and 2023 performance years. So beginning in 2022, new quality measures, so class 4 measures that meet data completeness criteria, will have a 7-point floor for their first year in the program and a 5-point floor for their second year in the program. This policy also applies to QCR measures, or also known as qualified clinical data registry measures, including those in the 2021 performance year. So QCR measures that meet data completeness in their second year of the program are subject to the 5-point scoring floor in the 2022 performance year. I just want to note that this policy doesn't apply to administrative claims measures. Measures will earn 0 points for the 2022 and 2023 performance years if data completeness is not met. However, small practices will continue to earn 3 points. Next slide, please. So some other new things for 2022. So several quality measure scoring policies, again, were finalized for 2022 and 2023. So for 2022 and 2023, measures will earn 3 points in the 2022 performance year, but will earn 0 points in 2023 year if case minimum requirements are not met. I just want to say that this does not apply to small practices, whereas small practices will continue to earn 3 points. Beginning in 2023 performance year, a 3-point scoring floor for measures with or without a benchmark will be removed. Measures that can be scored against a benchmark will receive 1 to 10 points, and measures without a benchmark will receive 0 points. And again, for small practices, I just want to note that they will still continue to earn 3 points. Next slide, please. I just want to go over telehealth guidance for 2022 for the quality performance category. So the use of telehealth capabilities has expanded due to COVID-19 public health emergency's effect on clinicians' abilities to perform patient-facing encounters. Some quality measures include telehealth interactions. MIPS eligible clinicians, groups, virtual groups, and APM participants should review other aspects of the quality action within the measure specification, including quality actions that can't be completed by telehealth. To determine whether the measure includes telehealth within the denominator, review the 2022 MIPS quality measure list. And those resources are available on this slide. Next slide, please. Now I'm going to discuss quality reporting for 2022. Next slide, please. So the quality reporting requirements. So to complete the reporting requirements for the quality performance category, you can report on at least 6 MIPS quality measures, including at least 1 outcome measure. If there is not an outcome measure that is available or applicable, you may report another high priority measure. You're also required to report on a defined defined specialty set. If this specialty measure set has less than 6 measures, you'll meet quality reporting requirements if you report on all measures within that specialty set. Or you can also meet the reporting requirements by reporting on all 10 required CMS interface measures. I just want to note that this option is only available to groups, virtual groups, and APM entities with 25 or more clinicians that register in advance. And the registration timeframe is between April 1st through June 30th of 2022. And it's of the submission period. So right now is the time to register if you want to report through the web interface. I just want to note that registration is not required for our Medicare Shared Savings Program, ACOs, or Accountable Care Organizations, reporting through the web CMS web interface measures as part of the reporting requirements under the APP. Next slide, please. I'm going to discuss just some terms that we use under quality reporting. So collection type, you may hear this term. Collection type is the way clinicians collect data for a MIPS quality measure. A MIPS quality measure may be collected in multiple ways, but each collection type has its own specification / instructions for reporting. So the collection type used has implications for scoring. So different collection types under MIPS are electronic clinical measures, or ECQMs, MIPS clinical quality measures, which are MIPS CQMs, qualified clinical data registry, or QCDR measures, Medicare Part B claims measures, CMS interface measures, and CAPS per MIPS survey measure. Next slide, please. So now with regard to reporting requirements, you'll also hear the term data completeness. So data completeness refers to the volume of performance data reported for the measure's eligible population. So to meet data completeness criteria, you must report performance data for at least 70% of the eligible population, which is the denominator. For Medicare Part B claims measures, we identify the eligible denominator patient population based on your submitted claims. So for ECQM, MIPS CQM, and QCR measures, you identify the eligible population in your submission according to the Quality Reporting Document Architecture, or QRDA3, or QPP JavaScript object notation, or JSON specifications. Incomplete reporting of a measure's eligible population or otherwise misrepresenting a clinician or group's performance, it wouldn't be considered true, accurate, or complete, and may be subject to an audit. Next slide, please. There are 3 MIPS quality measures that will be automatically evaluated and calculated through administrative claims if minimum requirements are met. So there is a new measure, the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions. And for this particular measure, you will have a case minimum of 18 cases and will only apply to groups, virtual groups, and APM entities with at least 16 clinicians. The other measure is the hospital-wide 30-day all-cause unplanned readmission rate for merit-based incentive program groups measure. And it will have a case minimum of 200 cases and will only apply to groups, virtual groups, and APM entities. And it replaced the all-cause readmissions measure in the 2021 performance period. The third measure is a risk standardized complication rate following elective primary total hip angioplasty and or total knee angioplasty for merit-based incentive payment system. So again, this will apply if there is a case minimum of 25 cases, and will apply to individuals, groups, virtual groups, and APM entities. And we'll also have a 3-year performance period that will start on October 1st, 2019 and end on September 30th, 2022, and proceed with a 3-month numerator assessment period. Next slide, please. This slide outlines what we consider how you submit quality data. When we think about who is a submitter, it can be you as an individual clinician, a group, virtual group, or APM entity representative. It can also be a third-party intermediary, QCDR, qualified registries, and health IT vendors, and a CMS-approved survey vendor. When we think about what, that is the collection type. So the what is a Medicare Part B claims measure, which is only applicable to small practices. It's ECQMs, MIPS CQMs, CMS interface measures. And then when we think about the how, it's how you submit the measures to CMS. So it can be, so if you are reporting as an individual, group, virtual group, or APM entity, it's, how you do so. So if you say you're reporting through Medicare Part B claims measures, it's through your routine Medicare Part B claims billing practices. If you're reporting ECQMs, you sign into the QPP website and you upload a QRDA3 file. If you're reporting on MIPS CQMs, you sign into the QPP website and upload a QPP JSON file. If you're reporting through the web interface measures, you manually enter your data or upload a file into the CMS interface or use the CMS interface application programming interface, or API. So this slide just outlines who is the submitter, which is the collection type, and how, which is the submission type. And then it also outlines when. So it outlines the timeline that we've already previously discussed. Next slide, please. Now I'm going to discuss quality scoring. Next slide, please. So for quality scoring, quality measures submitted for 2022 performance period will receive between 0 and 10 measure achievement points. You'll receive between 3 and 10 achievement points for measures in their third year based on your performance in comparison to benchmark if the quality measure meets the data completeness criteria. And if the measure has a benchmark, it meets case minimum requirements. So again, it's 3 to 10 achievement points. Also, you can achieve between 7 and 10 achievement points if the measure can be reliably scored against a benchmark, and the benchmark, and then also if the measure meets data completeness and case minimum requirements. You can also achieve between 5 and 10 achievement points if the measure can be reliably scored against a benchmark, and the measure meets data completeness and case minimum requirements. You can also achieve 3 achievement points if your quality measure meets the data completeness criteria, but either one, it does not have a benchmark, and or the case minimum requirement is not met. And then you can also receive 0 achievement points if your quality performance measure does not meet data completeness requirements, which varies by collection type, or doesn't have a benchmark. Next slide, please. We've identified topped-out measures annually through our benchmarking process. So measures that are topped out for 4 consecutive years can be proposed for removal through rulemaking. Process measures are considered topped out if the median performance rate is 95% or higher for non-inverse measures, or 5% lower for inverse measures. Non-process measures are considered topped out if the level of variance is is less than 0.10, and the 70th percent and 90th percentiles are within 2 standard errors. A measure is considered extremely topped out if the average performance rate is 98% or higher, and this is for non-inverse measure, or 2% or lower for an inverse measure. We consider this measure for removal if in the next rulemaking cycle, even if it's in the midst of a topped-out measure life cycle, but it may be retained in certain cases. Next slide, please. Now I'm going to discuss benchmarks. So each MIPS quality measure is assessed against its benchmark to determine how many points the measure earns. We establish benchmarks specific to each collection type. Whenever possible, we use historical data to establish benchmarks. For 2022, historical benchmarks for ECQMs, MIPS CQMs, Medicare Part B claims measures, and QCDR measures are based on actual performance data that was submitted to the Quality Payment Program for the 2020 performance period. If a quality measure doesn't have a historical benchmark for any of these collection types, we'll attempt to calculate a benchmark based on data submitted for the 2022 performance period. To score the CMS interface measures, we use benchmarks established under the Shared Savings Program. Next slide, please. So how benchmarks are converted to achievement points. So here we ask ourselves certain questions. So does the measure meet data completeness? If it's no, you earn 0 to 3 points. If it's yes, then the next question is, does the measure meet case minimum? If it does not meet case minimum, then you can earn 3 points. If it does meet case minimum, then the question is a benchmark available? If the benchmark is available, you're potentially eligible to receive 7 points for a measure in the first year of the program with no benchmark, and 5 points for new measures if there's a second year of the program with no benchmark. But if there is a benchmark, again, there is, different eligible points, and one could be 3 points, 7 points, 5 points. And then I just want to note that if there is a benchmark, as I highlighted previously, but again on this slide, you can achieve 3 to 10 points, 7 to 10 points, and 5 to 10 points. And it depends on whether a measure has a benchmark or not. Next slide, please. So on this slide, we ask ourselves whether or not a measure has a historical benchmark. So for quality measures that can't be reliably scored against a benchmark or without a historical benchmark, or receive 3 measure achievement points unless a benchmark can be established with performance period data. If measure doesn't also meet data completeness, it will receive 0 measure achievement points, except for small practices, which will receive 3 measure achievement points. Next slide, please. Beginning in the 2022 performance year, there are no bonus points available for reporting additional outcome and high priority measures. Again, is beyond the 1 required, or for measures that meet end-to-end electronic reporting criteria. The small practice bonus will still be applied for the 2022 performance period. So 6 bonus points will be added to the numerator of the quality performance category for MIPS eligible clinicians in small practices that submit data on at least 1 MIPS quality measure. This bonus isn't added to individuals, groups, virtual groups, or APN entities that are scored under facility-based scoring. Next slide, please. Now I'm going to discuss improvement scoring. For the 2022 performance year, you can earn up to 10 percentage points based on the rate of your improvement in this performance category from the previous year. So improvement scoring is calculated by comparing the quality achievement percentage score from the previous performance period, which is 2021, which is compared to the quality performance category achievement percentage score for the current performance period, which is 2022. The measure bonus points are included in improvement scoring. And as you see on this slide, this is the formula. Next slide, please. So now I'm going to discuss calculating the quality performance category score. So the quality performance category percent score is a product of the following equation. So it's the total measure achievement points divided by the total available measure achievement points times 100 plus the improvement percent score. Quality performance category percent score for small practices is a product of the following. So it's the total measure achievement points plus the small practice bonus divided by the total achievement measure achievement points times 100 plus the improvement percent score. Next slide, please. Now I'm going to discuss the maximum points available in the quality performance category. The maximum points available when submitting ECQMs, Medicare Part B claims, Part C claims measures, MIPS CQMs, and QCDR measures. So if you're submitting as an individual, the maximum points available is 60 points. If you're submitting as a group, virtual group, or APM entity, maximum points are available, and it will vary. So the maximum points available could be 60 points if any of the administrative claims measures don't apply. The maximum points could be 70 points if scored on any one of the administrative claims measures. The maximum points could be 80 points if scored on any combination of the 2 administrative claim measures, or a maximum points could be 90 points if scored on all 3 administrative claim measures. Next slide, please. Now I'm going to discuss facility-based measurement scoring. So facility-based measurement scoring will be used to calculate quality and cost performance categories when you're identified as facility-based, you're assessed, you're assigned to a facility with a fiscal year 2023 hospital value based purchasing or BP program score. The facility-based score results in a higher hospital VBP program combined quality and cost score than the MIPS quality and cost measure score we calculate for you. So that's how we calculate facility-based scoring. Next slide, please. Now I'm going to discuss reweighting the quality performance category. So your quality performance category weight will be redistributed to other performance categories if data isn't submitted for the quality performance category. because, let's say, for example, there are no quality measures available to you, or your 2022 Extreme and Uncontrollable Circumstances application is approved. So when the quality performance category is re-rated to 0, the weight distributions for each performance category are outlined below. And in this case, the quality performance category is re-rated to the performing interoperability performance category. So in this case, because of the redistribution, your promoting interoperability performance category weight is now 55%. And again, it's only in the event that quality performance category is re-rated to 0. And the other two performance categories stay the same. Next slide, please. Now I'm going to turn the presentation over to my colleague Ray to discuss the cost performance category.
Thank you, Lisa Marie, and hello, everyone. My name is Ray Desatel, and I'm the cost measure lead here at CMS, and I'll be going over the cost performance category. Next slide, thank you. So for the 2022 performance year, the cost performance category will account for 30% of your MIPS final score, and APM entities will have a cost performance weight of 0% for 2022. In like quality, the cost performance category has a 12-month reporting period, and the 2022 performance period is from January 1st, 2022 to December 31st, 2022. Next slide, please. And just to note, there is no reporting requirement for the cost performance category. CMS retrieves all cost data from your administrative claims. And there are a total of 25 cost measures for the 2022 MIPS performance year. This includes 5 new episode-based cost measures for 2022. And there are a total of 2 procedural measures, and of those 5, there are 2 procedural measures, melanoma resection and colon and rectal resection, 1 acute inpatient measure for sepsis, and 2 chronic condition measures, diabetes and asthma COPD. Next slide, please. And so cost measures are attributed to clinicians according to each measure's specifications. Each cost measure has 2 specifications documents, the measure information form, or MIF, which describes the methodology used to construct the measure. And then there's also the measure codes list, which contains service codes and clinical logic used in the methodology. In the MIPS 2022 Summary of Cost Measures document linked here provides an overview of all cost measures and is linked in this presentation. Next slide, please. And as I mentioned, there are 25 total cost measures for the 2022 performance period. This includes the Medicare spending per beneficiary, or MSP B clinician measure, the total per capita cost, or TPCC measure, as well as 15 procedural episode-based cost measures, 6 inpatient medical condition episode-based cost measures, and 2 chronic condition episode-based cost measures. And this table right here also documents the case minimums, as well as data sources for the different cost measure types. Next slide, please. And just to review some terms, so payment standardization is the process of calculating standardized claim payment amounts for clinician resource use. Benchmarks are calculated for each cost measure, and they're based on the performance year, not a historical baseline. And all MIPS eligible clinicians that meet or exceed the case minimum for a measure are included in the same benchmark. Attribution is the assignment of patients' treatment costs to clinicians. Each measure's attribution method is detailed in the measure information form, the MIF document that I mentioned previously. And finally, risk adjustment. So risk adjustment is used to account for differences in patient characteristics, such as clinical risk factors that aren't directly related to patient care, but may influence the cost of care provided. Next slide, please. And now I'll review the 2022 cost measures. Slide, please. Okay, so first off, we have the Medicare spending per beneficiary, or MSP B clinician measure. And this measure assesses Medicare Parts A and B costs incurred by a single patient during an episode window. There is a difference between surgical and medical episodes. So surgical episodes are attributed to any clinician who performed any related surgical procedures during the inpatient stay and to the TIN under which the clinicians billed for the procedure. Medical episodes are attributed to clinicians in two steps. So first, the episode is attributed to the TIN that billed at least 30% of the inpatient evaluation and management, or E&M services listed on Part B physician supplier claims during the inpatient stay. And then the episode is then attributed to any clinician in the TIN who billed at least one inpatient E&M service. For information on which CPT and HCPCS codes qualify as E&M services, and also to see which CPT and HCPCS codes are used to attribute episodes to a clinician or group, you can refer to the 2022 MIPS cost measure codes list zip file. And next slide, please. And so patients are excluded from the MSP clinician measure if they weren't enrolled in Medicare Parts A and B during the 93-day period prior to the index admission through 30 days after discharge. So this time frame includes an additional 90 days because this period is used to identify a patient's comorbidities used in risk adjustment. Patients are also excluded from this measure if they were enrolled in a private Medicare health plan at any time during the episode window or the 90-day look-back period. And they are also excluded if they resided outside the United States during any month of the performance year. And then episodes are excluded from the MSP clinician measure if the index admission didn't occur in a subsection D hospital paid under the IPPS system, or IPPS, or an acute care hospital in Maryland. And episodes are also excluded from the MSP clinician measure if the index admission was involved in an acute to acute hospital transfer. Next slide, please. The MSP clinician measure case minimum is 35, which means 35 total MSP clinician episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. And for groups, a total of 35 MSP clinician episodes must be attributed across all MIPS eligible clinicians who have reassigned their billing rights to the group's TIN. In addition, a clinician participating in MIPS as an individual won't receive an MSP clinician measure score if the clinician doesn't bill Medicare for Part B physician supplier services furnished to patients during hospital stays, and therefore doesn't meet the case minimum. And the MSP clinician measure is risk adjusted to account for patient age, comorbidities, disability, and illness severity. And a separate risk adjustment model is estimated for MSP clinician measures within each MDC or major diagnostic category. And next slide, please. So the MSP clinician measure is calculated by first dividing the population of index admissions, attributing the episode to a clinician group or clinician, excluding clinically unrelated services and calculating the episode observed costs, excluding episodes, calculating expected episode costs through risk adjustment, and then calculating the measure score. And the MSP clinician measure is calculated for each clinician, whether that be a TIN NPI or a TIN, by first calculating the ratio of standardized observed episode costs to final expected episode costs, and then multiplying the average cost ratio across episodes for each TIN or TIN NPI by the national average standardized episode cost. And multiplying the resulting ratio by national average cost per episode converts the ratio into a more meaningful dollar amount. And then this dollar amount is then converted into points by comparing the score to a performance period benchmark. The points contribute to the overall cost performance category score. Next slide, please. Next measure we have is the TPCC, or the total per capita cost. And this measure measures the overall cost of care delivered to a patient with a focus on the primary care they receive from their providers. And TPCC is attributed using 4 steps. So first, identifying candidate events based on the occurrence of certain primary care services that indicate the start of a primary care relationship. Applying service category and specialty exclusions to only include specialties and clinicians providing primary care. Constructing risk windows during which a clinician could reasonably be held responsible for the beneficiary's treatment costs. And then finally, attributing beneficiary months that occurred during a risk window in the performance period to TINs and TIN MPIs. Next slide, please. So patients are excluded from the TPCC measure if they were enrolled in both Medicare Parts A and B for every month of the performance year. They're also excluded from the measure if they were enrolled in a private Medicare health plan during any month of the performance year. They're also excluded if they resided outside the United States during any month of the performance year. And finally, patients are excluded from the TPCC measure if they are covered by the Railroad Retirement Board. And specialty adjustment is applied to the TPCC measure to account for cost variation across specialties and TINs. And specialty adjustment is performed at the provider level. Next slide, please. The TPCC measure case minimum is 20 patients. Clinicians and groups will only be scored if there are attributed beneficiary months across at least 20 patients. And with regards to risk adjustment, a TPCC risk score is generated for each beneficiary month using diagnostic data from the 12 months immediately preceding each beneficiary month. And for example, to determine the risk score for a beneficiary month of August 2022, diagnostic data from August 2021 to July 2022 will be used. And a patient's risk score summarizes their expected costs of care relative to other patients. Next slide, please. So when calculating the TPCC numerator is the sum of the risk-adjusted, payment standardized, and specialty adjusted Medicare Parts A and B costs across all beneficiary months attributed to a TIN or TIN MPI during the measurement period. The denominator of the TPCC measure is the number of beneficiary months attributed to a TIN or TIN MPI during the measurement period. And just a quick note, the TPCC measure score is expressed in a dollar amount, like I mentioned. It's calculated by dividing each TIN and TIN MPI's average risk-adjusted monthly cost by their specialty adjustment factor, resulting in a ratio. And this ratio is then multiplied by the average non-risk adjusted Windsorized observed cost across the total population of attributed beneficiary months to convert that ratio into a dollar figure. And just a reminder, your TPCC measure score, which is expressed in a dollar amount, will be compared to the 2022 benchmark to determine how many achievement points the measure will receive, and that'll be between 1 and 10. Next slide, please. Now we're going to discuss the acute inpatient medical condition and procedural episode-based cost measures. So these cost measures assess the cost of Medicare for items and services provided to a patient during an episode of care. These types of cost measures only include items and services related to the episodes of care for a clinical condition or procedure. Acute inpatient episodes are first attributed to the TIN billing at least 30% of inpatient E&M services on Part B physician supplier claims during the inpatient stay. They are then attributed to any clinician in that TIN who billed at least one inpatient E&M service during the inpatient stay. And procedural episodes are attributed to the clinician who builds the code that triggers the episode. Next slide, please. In acute inpatient and procedural cost measures are calculated via the following steps. So there's the trigger and define an episode. So episodes are generally defined by billing codes that differentiate between procedural episodes and acute inpatient medical condition episodes. Then we attribute the episodes to a clinician. Next, we assign a cost to an episode and calculate total observed episode costs. Next are the exclusions. We exclude episodes. Measure-specific exclusions remove unique groups of patients from the measures in case they may be impractical or unfair to compare the costs of caring for these patients to the cost of caring for the measure cohort as a whole. Next, we calculate expected episode costs through risk adjustment, and then we calculate the measure scores. And next slide, please. Okay, so the next few slides list out the 15 procedural episode-based cost measures and 6 acute inpatient medical condition episode-based cost measures. And for each measure listed in this table, just to go over some definitions. So an episode is opened, aka triggered by a certain clinical event referred to in the table and other documentation as a trigger. An episode window may, but not always, include a period of time before the triggering clinical event, and that's referred to as the pre-trigger period. And in addition, a period of time after the triggering clinical event is referred to as the post-trigger period. Some episode windows begin when the triggering event occurs and don't include a pre-trigger period. Therefore, they have a pre-trigger period of 0 days in this table. And the episode window used to calculate each of the episode-based measures is also listed in this table. And this table also lists what each of these measures evaluates, and then the setting for the claims data trigger. And I'll just go over the first one. So the first one is elective outpatient PCI. So this is a procedural measure. The pre-trigger period is 0 days. The post-trigger period is 30 days. This measure looks at patients who undergo elective outpatient PCI surgery to place a coronary stent for heart disease during the performance period. And it may be triggered based on claims data from ambulatory office-based care centers, hospital outpatient departments, as well as ambulatory surgical centers. You can go to the next few slides. And this table just again lists out the 15 procedural episode-based cost measures and 6 acute inpatient medical condition cost measures. Next slide. Next slide, please. Next slide. Next slide. And I think one more. Great. And again, for acute inpatient medical condition cost measures, episodes are attributed to clinician groups that bill at least 30% of the inpatient E&M claim lines during the trigger inpatient stay, and to clinicians who bill at least one E&M claim line under a TIN that met the 30% threshold. All TIN NPIs who bill at least one inpatient E&M service within a TIN that met the 30% threshold will be attributed the episode. And as a result, an acute inpatient medical condition episode can be attributed to more than one individual clinician. And for procedural episode-based cost measures, attribution is to any TIN NPI who bills a trigger code defined by CPT HCPCS codes on the date of the procedure or during a concurrent related inpatient stay. As a result, procedural episodes can be attributed to more than one clinician, and CMS doesn't exclude episodes if a patient already qualified for another episode. Next slide, please. And now for the case minimums. So the case minimum for procedural episode-based measures is 10, meaning 10 episodes must be attributed to a MIPS-eligible clinician or group for the measure to be scored. For groups, a total of 10 procedural episodes must be attributed across all clinicians who have reassigned their billing rights to the group's 10. And the case minimum for acute inpatient medical condition episodes is medical-based measures is 20, meaning 20 episodes must be attributed to a MIPS-eligible clinician or group for the measure to be scored. For groups, a total of 20 acute inpatient medical condition episodes must be attributed across all clinicians who have reassigned their billing rights to the group's 10. Next slide, please. And now to review the chronic condition episode-based cost measures. So these measures are constructed and calculated via the following steps. So first, we identify the patients receiving care. Then we identify the total length of care between a patient and a clinician group. We then define the episode and attribute the episode to the clinician group or clinicians. Then we assign the costs to the episode and calculate the episode annualized observed cost. Then comes the exclusions, and then you calculate the annualized expected cost for risk adjustment, and then the measure score is calculated. And next slide, please. So chronic condition cost measures have the following exclusions. So if the patient has a primary payer other than Medicare for any time overlapping the episode window or 120-day look-back period prior to the episode window, they're excluded. If the patient wasn't enrolled in Medicare Parts A and B for the entirety of the look-back period plus episode window, or was enrolled in Part C for any part of the look-back plus episode window, patients are excluded if the patient wasn't found in the Medicare Enrollment Database, or EDB, or they're excluded if the patient's death occurred before the episode end date. Patients are excluded from this measure if the patient resided outside the United States or its territories during the episode window, and if the patient has an episode window shorter than 1 year. Next slide, please. And I mentioned before, but there are two chronic condition episode-based cost measures for 2022. They are diabetes and asthma COPD. Clinicians and groups will only be scored on the measures if they're attributed at least 20 episodes for chronic condition episode-based cost measures. Next slide, please. Okay, so now I'll review the cost scoring. Next slide, please. As I mentioned at the beginning, so CMS uses Medicare Parts A and B claims to calculate cost scores. Clinicians do not need to submit any data or take any separate actions. The cost category is weighted to 30% for individuals, groups, and virtual groups, and is weighted at 0% for APM entities. And for the 2022 performance year, cost feedback and additional patient-level data will be provided in summer of 2023. And with regards to benchmarks, CMS calculates a single national benchmark for each cost measure based on the performance year, not a historical baseline period. All MIPS eligible clinicians will meet or exceed the case minimum for a measure are included in the same benchmark. And currently, CMS doesn't publish MIPS cost performance year benchmarks. Next slide, please. And for a cost measure to be scored, an individual MIPS eligible clinician or group must meet or exceed the case minimum. If one cost measure can be scored, that measure score will be used to compute the cost performance category score. If multiple cost measures can be scored, the cost performance category score is the equally weighted average points assigned to the cost measures. And if no cost measures can be scored, cost will count towards 0% of the MIPS final score, and CMS will reweight the performance categories accordingly. So cost would be 0, quality would be 55%, improvement activities would be 15%, in promoting interoperability would be 30%. Next slide, please. And so CMS will assign between 1 to 10 achievement points for each scored measure based on the clinician or group's performance compared to the performance year benchmark. Achievement points will depend on which decile range the performance on the measure falls between. And a reminder, an individual or group's cost measure performance is expressed in a dollar amount. A measure score expressed in between 1 and 10 points is derived by comparing your performance on the measure to the performance of all individual MIPS, clinicians, groups, virtual groups who were evaluated on the measure. CMS will automatically reweight the cost performance category for MIPS eligible clinicians affected by the extreme and uncontrollable circumstances or EUC policy. If a MIPS eligible clinician is located in an affected area, CMS will assume the clinician doesn't have sufficient cost measures applicable and assign a weight of 0% to the cost performance category in the final score. If other performance categories are reweighted, the cost performance category will always be weighted to either 30% or 0%. CMS won't redistribute weight to the cost performance category for the 2022 performance year. However, in cases when the cost and improvement activities performance categories are the only two categories scored, both categories will receive a weight of 50%. And next slide, please. And just regarding facility-based scoring, so facility-based scoring will be used for quality and cost performance category scores when all the following conditions are met. So you're identified as facility-based, you're attributed to a facility for a fiscal year 2023 hospital VPB program score, and the facility-based scoring methodology using your hospital VBP program score results in a higher final score than your final score calculated without the application of facility-based measurement. And with all that, I believe that's my last slide. So that's everything on the cost performance category, and I believe I'll now pass it over to Katie.
Awesome, thanks, Ray, and thank you, Lisa Marie, and thank you everybody else for joining us and hanging with us this long. I know that was a lot of information, really important info about quality and cost. So just wanted to say a couple things real quick. Reminder that all of our slides and recording, transcript, all that good stuff will be available on our QPP webinar library in the next week or so. So don't feel like you have to remember everything. We will have those resources available for you all to reference later on. We can go to the next slide real quick. And here are just some helpful links that we wanted to flag for you all related to today's presentation. So our MIPS overview quick start guide, eligibility participation quick start guide, and then of course our quality and cost user guides and information. All of this is on our QPP resource library, so really encourage folks to go there and take some more time to go through all these different resources. And with that, I'm going to go ahead and pass it over to, I believe, Olivia to go through how we're going to go through our Q&A. Thanks.
Thanks, Katie. Okay, so we are now going to start the Q&A portion of the webinar. And just as a reminder, you can ask questions via the Q&A box, which we see a lot of folks have already done, or through the webinar audio. And to ask a question via audio, please raise your hand and we will unmute your line so you can ask your question. So we will start with some questions that we've received from the Q&A box. And the first question reads, when will the web interface measure benchmarks for the 2022 performance year be available?
Hi, this is Lisa Marie. I'm not able to give it a very specific time frame in terms of when they will be available, but they will be available soon. I know that in previous years they've been available early on in the year, and we're in the process of developing those benchmarks. So we will be sharing them soon.
Great, thank you. And the next question says, can we report our MIPS measures through ECQMs, but report our Medicare Shared Savings Program measures through CMS web interface, since all of our ACO participants are not functional yet with ECQMs?
Right, so can you repeat just the first part of the question? Do they want to report both the ECQMs
Of course,
and the web interface?
Yes, it says, can we report our MIPS measures through ECQMs, but report our Medicare Shared Savings measures through web interface?
All right, so I'm going to answer this question because that's actually a complicated question. So if you are an ACO participating in the Shared Savings Program, you have the various options under the APP in terms of how you participate. So one option is reporting on 3 CQMs and then other measures as required under the APP. Or instead of like the 3 ECQMs, you can also report on the CMS web interface measures. So it depends on how you're choosing to report under the APP as an ACO participating in the Shared Savings Program. I'm not sure if the first part of the question is relating to you as a TIN participating in an ACO, but for example, if let's say you as an individual TIN, as a group practice, you have the option to report outside of the APP or the Shared Savings Program reporting requirements, but that would be considered in addition to reporting as part of the ACO, which the ACO does on your behalf. But as a group, you could do that if you wanted to do so. And again, that would be in addition to what your ACO would report on your behalf as an ACO.
Great, thank you. And Ray, just a question for you. Are newly enrolled Medicare beneficiaries excluded from the TPCC, or if not, how do you accomplish risk adjustment for those beneficiaries?
Hi, this is Joyce Lam. I'm from the cost team. So for TPCC, we actually use the HCC new enrollee model. So this takes into account enrollees who are new to Medicare, so that the risk adjustment model is calibrated for that particular patient population. So they're not excluded. We do have enrollment restrictions, so we do require sufficient data to make sure that all the beneficiaries we're capturing have comparable data. So that's continuous enrollment in Medicare Part A and B and not C for the duration of the episode plus any look back period.
Thank you. And the next question is for you, Lisa Marie. Is there any partial allotments given if only 4 measures are met?
So as I highlighted earlier in the presentation, I noted that the minimum reporting requirements are 6 measures. In the event that, let's say, within a measure set, or there aren't, measures applicable to you that total 6 measures, and let's say there's less than 6 measures, you're required to report on, let's say in a measure set, all of the measures in that measure set in the event there are less than 6. And you will not receive partial scoring, you'll just receive as if you submitted 6 measures. It's just like a numerator reduction because you're reporting on all measures within your measure set, and because there are no applicable measures, you're just being evaluated on the measures that are available to you.
Thank you. The next question, the use of high-risk medications in older adults doesn't have a benchmark. What is the maximum score a practice can receive on this measure?
So there are different elements with regard to whether or not and how many points a measure would receive. So for example, if a measure doesn't have a benchmark, but you meet the reporting requirements, meaning data completeness and case minimum, then you're able to achieve points for that measure. But I just want to highlight that, let's say a measure doesn't have a benchmark, that doesn't mean you just report half the measure, like half the data or a portion of it, but you have to meet data completeness, which is 70% right now, data completeness and case minimum. And that will then allow you to get various points. So I don't know if you want to go back to the slide. I don't know, slide, it has like the different pillars. If we could just show that slide again, just for a few minutes, I think that'd be great for folks to be able to see the different percentage points based on the different criteria of like a measure. So I don't know if someone can go back to that slide and I'll find out the number. Give me 1 second. It's slide 30. Thanks.
Okay. And just as a reminder, if folks do want to ask a question via the phone line, just go ahead and raise your hand and we will unmute you. And it looks like we have a few folks who have raised their hand so far. So we will start with Carrie Sweeney. Carrie, we will unmute your line and you can go ahead and ask your question. And just a reminder, you may have to unmute on your end as well.
Hello, I did not submit a question.
Okay, we will go ahead and lower your hand. And Uzma Irfan, we will unmute your line. And you may have, it looks like you're muted on your end as well. So you may have to unmute your line.
Can you hear me now?
Yes,
we
can hear you.
Yes. So I'm Uzma Irfan and I have a few questions. My first question is that I need to know the resource if you have available Excel sheet where I would know which quality measure has data completeness, benchmark, and what is the name of the resource. So I need to know that how should I choose the quality measures, which one will give highest points, which one will not give the highest point. That's first question. My second question is that you are mentioning that QCDR specifications, and then you are mentioning CQM quality resource. So I'm just confused that are these two separate resources or these are the same things? Hello?
Thanks for your question. So Katie, I don't know if you know if we have like a simple like listing of these, but I saw a question in the chat or in the Q&A box, and I know this may sound like cumbersome, but in the final rule, there's an appendix, and it's called Group Table C and Group Table D are actually the measures in which we list like substantive changes to those measures, and it actually outlines like each measure and each item in terms of how it changes. And then for like the list of measures that are like removed, we highlight those list of measures and we outline like why they're being removed. So I know of those places in terms of where you can get literally a snapshot. Well, I guess I should say a snapshot. It's a comprehensive listing for the information in terms of like measures that we're adding to the program, measures that we're removing, and measures with substantive changes, and then also measure sets with changes. I mean, that's all in the appendix 1 of of each final rule that we publish. So for 2022, it's the physician fee schedule final rule, and it's Appendix 1, and it's in group tables A, B, C, and D, and those are the tables that outline like new measures, measures with substantive changes, measures we're removing, and for measure sets, changes to those measure sets. I don't know, Katie, if there's other materials that we have that are maybe more like a snapshot of those resources.
Yes, how about the resource single resource, single source document? What is that? Single source document, single source document.
A single source document. Yes,
Yes,
I mean, the single source document I can think of as like the final rule. Katie, I don't know if we have our person who oversees our materials for the quality payment program. I mean, for the quality performance category. I don't believe she's on the line today to highlight exactly which ones we post, but I know that in the chat, we're also posting materials in there. So
yeah, so posting material in your chat also talks about two different things, QCDR specifications and then CQM quality specifications. Are those two different things, or which one is for CQM thing, or are those the same thing? Any comments on that?
yeah, so for each collection type, so whether it's a MIPS CQM or ECQM, we do highlight like the changes to the measures in those specifications. So for each collection type and for that measure, there will be like a single source, I think as you noticed, single source document that includes all of that information, which would include release notes, will include the measure specifications themselves. As you know, like the release notes, they highlight like the different changes. So yes, those are the source documents that you would review when, you know, depending on like the type of measure you're reporting.
Okay, thank you.
Hi, and thank you, Lisa Maria. Hi, Yusma. So I just put one in the chat, but so we do have, if you go to the QPP resource library, we do have in the zip files that have the different measure specifications, we also include those single source documents. So I just put a link in for our clinical quality measure specifications and supporting documents, and I can add our other ones that are available. They are all in the resource library.
Okay, thank you.
Okay, and just moving, we have a few more folks with their hands raised. So Robin Hook, we will unmute your line and you can go ahead and ask your question. And Robin, you may need to unmute yourself as well.
Hi, thank you. Yes, I think you already answered it from the prior question and also from the private chat. I got the link, so thank you very much.
Great. Lorraine Nardi, we will unmute your line and you can ask your question as well.
It's something along the lines of what was just asked that I'm still not clear on. Are the ECQM, which is reported with a QRDA2 file, and the MIPS CQM, which is reported with a QPP JSON file, are those just different groupings of information that is taken by your EMR vendor to submit? In other words, is that just a different way, or is all this info really coming from your EMR vendor that's looking at nominator and denominator, compiling a file and then sending it? Is this just two different files that they're sending your EMR vendor?
Allison, were you going to answer that question? If not, I can address it. So, well, I'll try to. So like a QRDA3 format or like a JSON format, it's specific to the technical, I'm gonna call it like the technical specs for the file. So it's like the very specific like technical elements that have to be captured, like from your like your vendor or and it's how then it would be received to CMS. So it's like that's like the technical files for how the data would be submitted.
So,
Does that answer your question?
so are you just saying, for instance, if you want to submit for mammograms, you're talking about the different technical ways that your EMR is picking up data about whether your patient has had a mammogram or not. It's still the patient has to have a mammogram from age 50 to 74 or so. It's just a different way that they're picking up the info from your EMR. Is that what you're talking about?
Yes, to some extent it's how, but it's also how it's then delivered to CMS.
Okay, but
So
then
like,
that's up to the EMR vendor needs to know that, right?
right. So your vendor will know, like if you're using an ECQM or a MIPS CQM, your vendor should know which format they should be sending it. That it's like a QRDA3, and you are correct that it's like how data is captured. So we have documents that outline exactly what's like in a JSON or what's in a QRDA3, and it's very, very specific, and it's all literally, it's like the code, it's like coding for how it would be formatted. So you are correct in that regard.
And are the QCDRs, those are just submitted by registries, qualified registries, is that correct?
Correct.
Okay, and actually I'm just dying to know one other thing. If you're trying to submit one measure, are you allowed to submit that measure in two different methods? In other words, can you submit that measure as an ECQM, as a MIPS CQM, and get the score of whichever one is better for one measure, or can you only use one method to submit one measure? I know you can use different methods to submit different measures, but what about for the same measure?
You could, I mean, if you wanted to report on the same measure using different collection types, you can do that. I will note that the only exception to that where it's not applicable is like with the CMS web interface measure. So for example, if you're reporting the web CMS web interface measures, you have to, you either, well, for like ACOs, you have to do that if that's like the means you're choosing to do, or you do like the 3 ECQMs. But let's say you're just participating in traditional MIPS, you have the option to report the web interface measures. If you report on the CMS web interface measures, those are the measures you're going to be scored on. But if, let's say, you choose not to report the web interface, even though, let's say, you registered, you can submit other measures, even if they overlap with the CMS web interface measures. But my point is that you can report the same measure using different collection types, but there are exceptions to where you can't. And I just noted that with like the APP for ACOs and web interface users who actually report on the web interface measures.
Oh, okay, that's great. And you referred, I'm sorry, to something before about a 5-point or a 3-point score. What were you talking about there?
Can you go back to slide 30? I don't want to like hold up the line because I think we're almost at time. But if the slide can go to, if the PowerPoint can go back to slide 30, that would be great. So she can see the different scales for point distribution. That'd be great. So this is a different distribution. So I was able to answer your question. Yeah, so,
Get it now. It's the characteristics of, what's being submitted creates that 3 or 5 point thing. Okay, I get it. Thank you.
you're welcome.
Okay. Well, I know we are at time, so Katie, I will pass it back to you to close us out.
Okay, great. Thanks, Livia. And thank you everybody for hanging on with us this long. We really appreciate it. And thank you so much for engaging with our Q&A session. And again, the materials should be available on our webinar library in the next week or so. And we will talk to you all next time. Thank you.